We are good to go, sir.
Right. Good evening to all. I'm Nakul Patil, working as a product manager, and we at Emcure iHERA division, Materna is our pro brand and epitome of quality and success. We are thankful to International Human Embryology Research Academy for giving us this opportunity to host this webinar and be a partner for this wonderful academic initiative. Especially, I would like to thank you to Dr. Ved Prakash, Dr. Sanjay Shukla, Dr. Charudat Joshi, and now may I take this opportunity to introduce the today's coordinator, Dr. Nidhi Singh. I'm sharing screen. Yeah, Dr. Nidhi Singh, she did a MBBS MD in anatomy, ENB anatomy, MNA, MS, DC, and now she is present working as a consultant and clinical embryologist. She worked at the Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi, IVF and Reproductive Biology Center, Maulana Azad Medical College, and LNJP Hospital, New Delhi. Welcome, Dr. Nidhi Singh.
Good evening, Mr. Nakul.
Then our second coordinator, Dr. Miss Ishwita Tanwar, she did a MSc in biotechnology. She is a senior embryologist and laboratory in charge with 8 years experience in the field of embryology at New Life India Fertility Clinic Private Limited, certified in advanced skill set embryology training, and ASRM certified clinical embryologist. She did American Society of Reproductive Medicine, and she is a member of AC India and ASRM Society. Then next, our coordinator, Dr. Nancy Sharma. She is a chief embryologist and lab manager. She is a ASRM certified embryologist, certified from the ASRM in fertility preservation for reproduction health, provides embryo and blastocyst biopsy training workshop from Embryology and PGD Academy, UCL. She did embryology certification course from Indian Fertility Society, IFS. She has a work experience around 7 years in the field of ART. Welcome, Dr. Nidhi Singh, Nancy Sharma, and Dr. Ishwita Tanwar.
Yeah, thank you, Mr. Nakul,
Yeah.
for the kind words. And I'll start my screen sharing.
Yeah, please, doctor.
So, good evening to you all. Is it visible?
Yeah, visible.
Yeah, on this auspicious occasion of the Gashtami, we bring you beautiful 4 topics with our experts. And I would like to introduce our first moderator, Dr. Ved Prakash, sir. Sir is a lab director at Southern Fertility and IVF Center, Delhi NCR. He has done MSc PhD. He is the president of ACE Academy India currently. Sir is a founder of iHERA Research Academy. He's member, Virtual Education Committee, Society of Study of Reproduction since 2021-22. Sir is a faculty in fellowship in ART in Amity University, Noida. He's visiting faculty for MSc in ART in Mysore University. He has 8 chapters contributed in textbook and published papers, national and international journals. His areas of interest are in vitro fertilization to blastocyst formation and innovation in embryo culture system. Welcome, sir. Next is Dr. Sanjay Shukla, sir. Sir is lab director at Baheti Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. Sir has done PhD in life sciences, worked on the early diagnosis of typhoid fever, working in the field of human reproduction since 1998. Sir has done fellowship in 2006 in the biology of reproduction from Argentina. Sir is vice president of ACE India. He's chairman academic wing ACE India. Sir has editor newsletter of ACE India. Welcome, sir. And I also welcome the third moderator, that is Dr. Charudat Joshi, sir. Sir is MSc PhD CART from Belgium. He has done his post-graduation in life sciences in 1993, special training in ICSI IVF and sperm from GNK Belgium 2001. Sir has also done special training for embryo freezing from KK Women's Hospital, Singapore in 2004. He has done special training in laser-assisted hatching from Belgium and PhD from Germany, and done doctorate in life science in 2018. Sir is the executive member of MP-ISAR chapter and executive committee member of MP-IFES chapter. Sir was vice president, past vice president of ACE, Academy of Clinical Embryologists, and past president of ACE in 2014-16. He is a medical director of Genes India ART Bank. Welcome, sir. And I would like to welcome Dr. Charudat Joshi to please give the welcome speech. I'll just stop sharing the screen.
Thank you, Nidhi, for such kind introduction. And it is always an endeavor in our iHERA programs to bring our viewers more and more about what is going latest in the field of ART. And in today's topic, we are going to cover from gamete till blastocyst. As we all know, blastocyst transfer is a very common procedure now. To get a good blastocyst, it all starts from selecting a patient and making good gametes. If gametes are good, then only you can expect a good blast. And in between, there are so many events like the culture conditions of the lab, then the media disposable which we are using. So in this today's webinar, we would try to cover all these aspects, starting from the getting good gametes till the good blastocyst formation, because this is an $100 million question asked by patient when the pregnancy test becomes negative. Sir, सब अच्छा था, फिर भी ऐसा क्यों हुआ? So we have to be very cautious and very careful in making our embryos. So let's listen from experts about the gamete formation till the blastocyst formation. So on behalf of iHERA, I would like to welcome all of you for this event, and hope to listen all latest developments, great experiments in this field. So over to you, Nidhi, for further proceeding. Thank you.
Yes, sir. So I welcome my first speaker, Dr. Sandeep Tanwar ma'am. Ma'am is senior consultant NOAA South Infertility and IVF. She's a leading infertility specialist in the city with over 26 years of experience in virtually all facets of the diverse field of infertility. She's a clinical and research career span. She has a clinical and career research span of over 2 decades. Dr. Sandeep Talwar has been actively involved in teaching DNB students and training fellows in the infertility and reproductive medicine. She has been a beacon of hope to thousands of infertile couples. She has honed her skill in reproductive medicines from France, and she joined the IVF unit in Sir Gangaram Hospital at Delhi and was actively involved in various activities that included plethora of academic and technical meetings and workshops in various parts of the country. In 2011, she established her own infertility and IVF department in BL Kapoor Hospital, Delhi in 2011. She is appointed as an examiner for fellowship in reproductive medicine under National Board in 2011 and also as an inspector of FNB accreditation hospitals. Among the many awards that she has won in her 20 years career are the Appreciation Award by Foxy for 2 consecutive years in 2003 and 2004, and the Academic Excellence Award by Delhi Medical Association in 2013. Good evening, ma'am. I welcome you.
Thank you so much, Nidhi, for your kind words, and thank you, Dr. Wade, and thank you for Dr. Charudat Joshi for inviting me today in your esteemed platform, and I'm thankful to you all for calling me today and just sharing a few thoughts. As Dr. Charudat was talking in his introductory note, that all of us, it could be clinicians, it could be embryologists, we are all concerned with only one thing, that is to transfer a good blastocyst and then to have a successful pregnancy. So what is going to work for us? It's $1 million questions, and we have to coordinate with each other. Dr. Wade knows I eat up his head quite a lot on, and I discuss each and every case I would discuss as to how to go forwards. Because unless we are coordinated with each other, things don't work out well. So we have to just match our stimulation and give you good oocytes so that you are able to give us good blastocysts in turn. So how do we optimize stimulation for oocyte quality and quantity so that both the things which we give as clinicians are of the optimal number and quality. So first question arises, is there any association between oocyte quality and quantity? Are they inherently linked or no? So the only thing which actually connects both oocyte quality and quantity is the age. With the increasing age, the quality and quantity of oocytes goes down. Now, if we take out age and if we take out age independent factors, then there may be a decrease in oocyte quality, but not quantity, but not quality necessarily. And what are these conditions in which the quantity will decrease, but the quality remains same? Like endometriosis or past surgery for endometriosis, the oocyte quantity is decreased, but not the quality. Similarly, let's take a scenario. We have a young girl with poor ovarian reserve, and we have a advanced age woman with poor ovarian reserve. Now, what is the difference between these two scenarios is a young girl with a poor ovarian reserve will have decreased quantity of oocytes, but her quality is maintained. Whereas a woman with advanced age, there is a diminished oocyte quantity as well as the quality is also hampered. So this is the difference between quality and quantity. So they are not necessarily linked with each other. The other question comes, it's $1 million question. What is the optimal number of oocytes required to achieve a pregnancy? Is there any magical number or there is no number which is there? So this is a chart from Sunkara et al. Human Reproduction 2011, where the egg number was compared to the live birth rate. And we can see that the optimal number, if we see the graph, it's anything around between 15 and 20 when the live birth rate is the maximum. And so this is how the association is. So less is the quantity, the less is the number of the oocytes, the lesser is the live birth rate. This again shows the same thing. So again, we come to the same question. How many oocytes do we need to maximize the cumulative pregnancy rates after utilizing fresh and frozen embryos both? So this is again the same thing. It's another paper by another group. So we can see that they've made groups according to the number of 1 to 3 oocytes, 4 to 9, 10 to 15, and more than 15 oocytes. So you see there is a steady increase in live births as the number increases, number of oocytes. So again, same kind of studies there. So we'll come to this question again, but if to achieve a certain number of oocytes, what is the stimulation we should be using? Should it be mild stimulation, like what in a few years back, it was coming to mild stimulation protocol. They said you increase the dosage, the gonadotrophin dosage, and what you have is you may have more number of oocytes, but the quality is hampered. You have more aneuploidies, you have more ovarian hyperstimulation. So came on to a thing called as mild ovarian stimulation. So the proponents for mild ovarian stimulation was it decreases the cost and decreases the side effects of ovarian hyperstimulation associated with ART. Now, what were the people who were said no, don't do mild ovarian stimulation, do the standard stimulation protocols, and then do the IVF cycle according to that. So the proponents for the standard stimulation protocols was that the mild ovarian stimulation offers less oocyte yield as compared to regular standard protocols. And hence, there was this paper from Orvito et al. In 2017, which said in routine use, there is no use of mild stimulation protocols for IVF. So similarly, another group has said that mild stimulation protocols using clomiphene citrate or letrozole does not seem to be the method of choice in a conventional, in a good prognosis subfertile women. So hence, as of date, there is nothing which supports that, for any patient, you start just giving mild ovarian stimulation, and standard stimulation is the rule. So does the size of the cohort, now we come, why the size does not, why is the size not hampering the oocyte quality? So you would have, after a certain number, definitely you will have ovarian hyperstimulation, but you would have normal oocytes also. So what do? Now the number of blastocysts and age of the patients, it's the euploidy is not related to the number of oocytes we retrieve. So in the other words, if we increase the oocyte number, the aneuploidy rates do not increase. So again, this is what is reported from another paper. So what is ideal? The dose of gonadotrophins. There is no correlation between the dose of gonadotrophin given to the number of oocytes retrieved and the risk of euploidy in each age group. This is a very, very important statement. Hence, we can give standard ovarian stimulation protocols and still not compromise the euploidy or the euploid status in each age group, which we are worried about. And implantation rate of euploid embryos were not affected with the number of gonadotrophins or the amounts of gonadotrophins used. So what do you need for a successful pregnancy is a good blastocyst and endometrium, which is receptive, or the implantation rates, so that depends on the quality of endometrium. So both these things are not being affected with the amount of gonadotrophins used. So the ideal number, the magic number, is somewhere around 15. However, if we start increasing the number of oocytes, then what happens is that you have more risks of ovarian hyperstimulation. Now, having said that people of my era, people like Dr. Ved or Dr. Charudat Joshi, who've been practicing for very long, know that there was a scenario in our time when we started IVF practice, when cryopreservation was not so good. And we were scared that if we do a frozen transfer, maybe our pregnancy rates are going to suffer. So we wanted to do, we wanted to just transfer in the same cycle. We did not want to go for a frozen cycle. But with the advancement in the cryopreservation techniques and the vitrification being so good the way it is, we are not scared of doing a frozen transfer or a freeze-all strategy. So we can do optimal stimulation. We can go for a freeze-all so that you have good number of oocytes and we don't have ovarian hyperstimulation too. The other thing which we can do, which we can make use of, is if you have less time, say a person is undergoing something like, for cancer, they are undergoing fertility preservation, or she has come from somewhere outside, which we guys see so many times, that person is flown from overseas and says, ma'am, I only have this month. And we see that, this is the only cycle I can do to collect all the make the blastocyst best number which I can do. So what do? I can do something called as dual stimulation, in which we stimulate in the follicular as well as the luteal phase. and the quality and the quantity, as well as the euploid status, it does not differ in either the follicular or the luteal phase stimulation. Hence, this can also be used as a method of stimulation and getting optimal number of good blastocysts in a shorter period of time. So if we compare the embryonic status of natural cycles and stimulated cycles, the embryonic aneuploidy rates do not differ in natural cycles following mild stimulation and intense stimulation. So hence, gonadotrophins do not have a role in embryonic aneuploidy, which we were very, very worried about. And I would say in 90s, there were lots of papers which said that if the terminal E2 on the day of trigger, if it is beyond say 3000 picogram per ml, then your implantation rates and all these rates all go down. So we were very, very scared, and because this is what the evidence said, but now the evidence suggests otherwise, because the embryo biopsy and all the other tools which have come to us have made us study the blastocyst and the genome so well that we know that this is not going to affect the aneuploidy or the euploid status. So what about the type of gonadotrophin? Does that also have any role? Now, what about adding LH? The physiological role of LH during follicular phase is unquestionable. Impact during a controlled ovarian stimulation remains controversial. Now, you can add LH to FSH in selected group of patients, that is our elderly females or the poor responders, where it is indicated. But in other patients, in normogonadotrophic patients, there is no role of adding LH in the beginning of the stimulation protocol. So this is a paper which compares highly purified and the recombinant FSH, and it is studying the oocytes retrieved, number of fertilized oocytes, embryos, and embryos transferred, quality fertilization, and the fertilization rates and the embryos formed. So there is not much of a difference between recombinant and the HMG protocols. The number of oocytes, this is a MERIT trial, which is one of the biggest trials which was conducted. And this shows that oocytes were more with recombinant FSH, but top quality embryos that you got were more with HMG. Hence, you have to individualize for what patient you want to give what protocol. So it is not that one size fits all. So you have to see as to what is your type of patient. Is it a patient who's a PCO patient? It's a poor responder. It's a normogonadotrophic patient with a male factor. Or what is the type of infertility you are dealing with? And to make a proper protocol is something which I feel is the most difficult part of doing IVF. To do a good pickup of a certain level requires expertise, or to do a good transfer too. But the most difficult part is doing a proper stimulation and to know as to what stimulation protocol and what dose to start with and how to individualize is the one which is more difficult. So I don't need to show you, people know what role the cumulus cells have in embryonic development. I don't need to teach you this. This is just a very interesting slide which shows that how age is impacting your euploidy rate and the number of blastocysts. So if age is less than 35 years and with 6 COCs, we get around 5 M2 for 4 oocytes fertilized, 2 blastocysts, euploidy rate 52%, and you can see that as the age goes there, the euploidy rate is falling from 52 to 20. and you require much more oocytes to get the same number of, to get the blastocysts. So this is not something which is very, very unusual. And as we guys are seeing that more and more of our patients are coming, either they are between 35 to 39 is the main age group that we are seeing, at least in our clinic in South Delhi, because girls are getting married late. So rarely I see people who are, early 30s or maybe less than 30. I don't think we see many patients. So how do we sum up? What do we say? What is the take-home message we have? So increasing oocyte yield will increase the chances of pregnancy only up to a limit. A higher yield may lead to more complications and eventually more abnormal embryos. The goal is to get 15 oocytes by individualizing therapies. Type of drug and stimulation influences the quality of embryos, and quantity is therefore overruled by quality and better pregnancy rates. So what do we need? End of the day, we just need one good blastocyst to get you a pregnancy. So the number that way is not that important. What is important is what quality we get, and the increasing oocyte yield is an opportunity. How does increasing the yield help us is we get more euploid embryos, and the aim is you get around 15 oocytes but avoid ovarian hyperstimulation. And the controlled ovarian stimulation protocol should be tailored to individual phenotype, maximizing number of oocytes yield for poor responders and fine-tuning hyper responders. So if you can find that balance, that poor responders and hyper responders, they both get stimulated optimally, that is what is the trick, or that is what is the art. Thank you so much for patient hearing. Please, any questions?
Nidhi, is there any question?
No, sir, I could not see any questions, sir.
Can I ask one question?
Yes,
here?
yes.
Good evening, madam. This is Charudat Joshi.
Yes, yes, I know you.
I am running at a bank, and many times it happens that the donor what we comes to us, the report says that the oocytes are not very good quality. Then sometimes the recovery is very poor. So the main reason comes out to be that they might have donated many number of times and all. So what I just want to know, what is your experience about, like, if someone is donating, on if a donor, what parameters you can look for other than follicles, what we can see for that she is suitable for an optimal stimulation or not, or are we are going to get good quality of oocytes?
Dr. Joshi, the scenario now with the new ART bill coming is they say that we can only get 7 oocytes. So what I normally see, or what I would see, I reject PCO patients for donors, because any polycystic patients with PCOS, you may get more number of oocytes, but the quality is not so good. Secondly, age is, I'm sure you must be seeing the age, what is there. So age should be not more than 30 years is what I feel. And secondly, when you do the antral follicle count, who's the person who first does the ultrasound is very important.
Correct.
So what should be your AFC should be around 10, 12 is what is the optimal number. It should not be a PCO. It should be a normogonadotrophic patient. And if you can do the AMH, I know the expense goes high, but maybe in the interest of getting the optimal number of oocytes, one AMH is not going to trouble us. So if the AMH should be not more than 4 or 5, and it should not be even less than 2, because neither do you want a poor response. Even we have had patients, Dr. Ved knows that you are stimulating our donors and you get very less number of oocytes. So neither do we want a number to be very less, or nor do we want them to be, going into hyperstimulation, because once the donor goes into a hyperstimulation, you've had it. So that is what you check properly. The first person who does the baseline scan has to see very well as to what is the number of oocytes, what is the antral follicle count, is she PCO, is she non-PCO. And if you can somehow ask the history कि आपने कितनी बारी eggs दिए हैं, sometimes they tell lies. They tell lies. Sometimes you have these big CL cysts which you see, and then they, that myth is under. Then you know that they have donated.
Yes, and the age also, you never come to know the real age. Actually, whatever is written on their Aadhaar card is all manipulated one. But the still question remains the same, that even sometimes we feel that after doing AMH also, it doesn't get good response. My second query is that what should be the minimum dose you think of that to start with a donor stimulation? And as you said, PCOD, so I think it is other way around. Whatever donors comes forward, they are all mostly PCO.
No,
right.
I personally, if you ask me, in my so many years of experience, I don't feel the PCO donors to be, because you may get number, the quality is never good. So I would not that, and minimal dose, I feel that our Indian patients don't respond to less than 225 units.
Okay.
Is what is my personal experience in so many years of my practice. I may decrease, but I will not start with less than 225, because I feel that if we give 150, it looks very nice on paper, but our people somehow don't respond to 150. Somebody asked about AMH. If you feel AMH is not the reliable, sir, then AMH and AFC, if you combine both the things, then the literature says that these are the best markers of ovarian reserve, antral follicle count and AMH together.
Yeah, and I think the other possible way of getting good information from AMH is get it done from some standardized lab. That is very important.
Some standardized lab, whatever you are using, which you are happy about, and you as a person, as a scientist, know exactly as to what is the credibility of your results. So if you are happy with a certain level, then I think that's what you should do, because you guys are so experienced that you would know exactly which lab is good.
I think we should organize now one in scenario of this new ART bill. We should organize one webinar on how to stimulate the donors.
How to stimulate? Yes, this is going to be very tough. Recently we had some person, and so then the girls come, and then maybe our white hair are needed for that.
Correct. I agree. Okay, madam. Thank you for nice.
Actually, thank you, ma'am. It was wonderful talk, and I think you showed us so many things in your lecture, and definitely people will get benefit out of this. And one last thing I would like to say here, just you told like that individualized stimulation is best way to go. I think we have to learn how to individualize the stimulation. This is the best way to go, because so many centers and so many clinicians I have seen that they started with same dose to every patient, not even check the AFC, AMH, etc. But they started with that high dose or sometimes very low dose, and at the end they will get, maybe patient will be in hyperestimation, or maybe they will get low number of oocytes. So it is better to start with all the patients with individualization to get the better outcome. Thank you, ma'am. Thank you so much.
Thank you so much for calling me, inviting me. I'm grateful. Thank you so much.
Thank you.
Thank you, ma'am. I would like to call Yoshita. Please take over.
Okay. Thank you, Nidhi. Now I welcome Dr. Sarabjit sir. He is an MD in AIMS, and he's a senior consultant and Chief Embryologist at Artemis Health Institute since 2009. He is a certified iHERA and IFS clinical embryologist and convener IVF. Sorry, sir. He is a convener IFS SIG clinical embryologist 2018 and 2020, and award for best convener special interest group of division in 2018 to 2020, and he is a champion of ISAR award at ISAR conference in 2020. Convener IFS SIG applied genetics in 2020 to 2022, and his area of interest is cryobiology and male infertility. Sorry, sir.
Thank you, Yoshita, for the nice introduction. And can I share my screen now?
Yes, sir.
So Dr. Ved called me a couple of days ago and asked me to speak on blastocyst culture, tips and tricks. So it's a very wide topic, and I don't know where to start and where to end. There is so much in these 20 minutes. I don't know I can do much justice to, in terms of, covering everything. But yes, I'll touch upon whatever I can think is important. So let's start without wasting much time. Embryonic development, if we look at the pre-implantation embryonic development, it starts with the fertilization of oocyte, then zygote, formation of zygote, cleavage, compaction, decompaction of morula, and then ultimately cavitation takes place and the expanded blastocyst is formed. It herniates and implants. This is about the in vitro and in vivo development of embryo. So we are concerned today with the blastocyst culture. So I'll just go into the historical aspect. And since the first IVF birth in 1978, the optimal time to perform ET has remained controversial. Cleavage stage, day 2 or day 3 ET was generally used in IVF, and it became the established norm in practice. This intentional placement of day 2 or day 3 embryo directly into the uterine cavity is a non-physiological procedure. But there was little to offer as an alternative due to the inability of human embryos to sustain culture till the blastocyst stage. So we have come a long way. In older days, people were doing cleavage transfers predominantly. Now, with the development of new medias and sequential media primarily, and other improved culture conditions, now we have come up to the stage where some of the labs are doing only blastocyst transfer, and some of them are customizing between patients and predominantly doing blastocyst transfer like we do. So if I look at the history of culture media, it started with the development of Ringer's lactate, and which was a very basic media based on blood serum and was able to support frog heart in vitro. So now we have come up to a stage where culture media contains around 80 components, including nutrients, vitamins, and growth factors. And in between, if you look at the development, I will not go into the development, but the key event concerning today is the development of sequential media by Gardner in 1996, which inspired people to go for blastocyst transfers. They could decipher the composition of nutrients required for cleavage, and then they manipulated the composition in blastocyst stage media, and ultimately they came up with the sequential media. Having said that, with so much of development, still there is a feeling that there is no culture media which is truly optimized for human embryonic development. More important is the culture system as a whole. So embryo culture is much more than media. It is plasticware, it includes media, it includes oil, and so many components which we'll cover in these 15-20 minutes. We're going to discuss these slides. So the culture system primarily it aims to maintain the viability of gametes, sperm function, oocyte competence, maturation, decrease the embryonic stress in terms of minimizing the exposure to changes in temperature, pH, carbon dioxide, and having achieved this, it will ensure normal embryonic development, and it will increase the implantation rates. And this is the primary objective of having a good culture system. So if you look at the culture system, the components which I've already discussed, some of them I'd like to just recap: media, macromolecules, gas phase, type of medium overlay, the culture vessel, incubation chamber, ambient air quality, even the embryologists themselves, the oil overlay, which gas phase, 5% CO2 or 20% CO2, number of embryos per drop. So many things are there: the tissue culture ware supplies, number of embryologists, number of incubators, the air quality. I mean, there are so many factors which you have to control. And in this study by Rieger et al. In 2012, he said that there are almost 175 factors which you need to control in the lab. When after that only you can optimize and think of a blastocyst culture. So what are the challenges for a blastocyst culture? Briefly, it can be divided into the lab factors can be divided into the micro and the macro. Macro starts with the lab design and the air quality. Lab design, in case of a new lab, you can definitely, go for a better design lab in terms now. It's a segmented design, which is most common nowadays. But most of the labs are still being retrofitted inside existing facilities, and it becomes difficult to achieve the proper air quality and the proper optimum culture conditions. If you look at the micro parameters, it is again, which I mentioned: temperature, oxygen, carbon dioxide, which influences the pH. If you look at the equipment, a good choice of appropriate selection of equipment is something which is foremost, and without which you really can't proceed ahead. And for this, you require a good knowledge of technical knowledge of instruments. Which sensor, there are so many things which you have to know. And these instruments have to be regularly maintained, calibrated, and the possibility of malfunction has to be kept in mind. And they do give warning signals, so you should be aware of those things also. Methodological factors: it requires a correct technical approach and correct SOPs which are practiced in the lab and as well as clinics to ensure optimum results. If you look at the contact materials, anything which comes in contact with the embryo during its development is important, and you should be very careful about selecting those articles. So culture media, plasticware, gases, handling devices in which ET catheter, ICSI microtools, OPU needles, so many, the list just goes on. If you look at, there is definitely the danger of unseen things like volatile organic compounds and airborne chemically active compounds. So the choice of gas and the design of gas supply system becomes extremely important. Again, as I mentioned earlier, the lab design is important because ultimately, the lab design will take care of minimizing VOCs as well as airborne chemically active compounds. You should have a HVAC with at least 14 to 16 air changes, and all the filters in place. The choice of building material is very important. You should be very careful about the paints you use, the adhesive sealants, HVAC system, air quality, cleaning products, air fresheners, VOCs released by equipment. So the list just goes on. I mean, there are so many things which have to be kept in mind. The choice of workstation is very important because you need to have a very precise and consistent temperature control. Incubation system is again important, which we'll discuss in slides to follow. The temperature is very important during follicular respiration, transport of aspirates to the egg workstation, that is a laminar hood. The egg search procedure is again extremely important step, and ultimately it ends with something which is extremely important, which is the handling of oocyte cumulus complexes, or the handling of embryos and oocytes in general during those 5 days. I think embryo handling is one of the extremely important factor which is influencing the result, besides the factors which we are going to cover in this presentation. A stable CO2 which leads to stable bicarbonate buffered pH, and reduced O2 incubators are in flavor now, and they protect the embryos against oxidative stress. So I'll just run through the slides because of paucity of time. So I'll just cover the importance of temperature control because if temperature control is extremely important for a successful IVF culture, and the microtubules are extremely thermosensitive. Any brief change in temperature for even for 90 seconds or 45 seconds will lead to the microtubules disassembling, and ultimately they might lead to aneuploidies. So great care should be taken to maintain the stable temperature, especially during manipulation in processes such as ICSI. And having said that, I would like to just emphasize on the fact that temperature within heated areas in a laminar flow hood is notoriously inconsistent. So it's a very good investment if you can buy a state-of-the-art laminar hood with a heated stage. Most of the laminar hoods in our country, they come with a cold stage, with a non-heated stage. So this study by Wang et al. Was a landmark study in which he demonstrated that a brief 5-degree change in temperature for just 90 seconds caused the microtubule to disappear, and within 5 minutes and 10 degrees changes in temperature, the microtubule was gone. Again, he tried to reverse the temperature and he could see traces of microtubule coming back, but that may not be always true, because the recovery of microtubule is something which is not a very desirable factor in terms of temperature fluctuations happening in the system, as well as the recovery is always temperature, as well as that it is dependent on the duration of exposure as well as the intensity of changes in temperature. So better is to invest in a good laminar hood during your embryo handling and manipulations. So a suboptimal temperature control can lead to fragmentation, delayed cytokinesis, multinucleation, which is a very detrimental factor in terms of, that if you see multinucleation, you have to omit that embryo. It can lead to low fertilization rates, reduced pregnancy rates, and higher incidence of biochemical pregnancies and blighted ova. Ambient temperature control is again very important, and that is why we recommend having a HVAC system with at least 15 air changes and ability to maintain 24 to 25 degrees of temperature and around 45 to 50% of relative humidity. So this study by Butler et al., they demonstrated that the room temperature influenced microscope stage temperature, and it significantly influenced the changes in temperature in all the microscopes, slide warmers, heating blocks, incubators. So you have to place the incubators in the right location. There should be no direct vent opening on the face of the incubator or right on the lid of the benchtop incubator, as well as the laminar hood stage, as well as the microscopes should be away from direct flow of air. So this was a study which showed that temperature variations are there, which are commonly seen inside commercially available IVF incubators. Temperature in the top shelf was closer to digital incubator temperature and significantly differed from the temperature of other shelves. So the front side of the shelf displayed no significant difference from the rear side or the back side. So these things have to be kept in mind. The upper shelf can differ by 2 degrees from that of a lower shelf. So you should keep these things in mind while you are culturing the embryos for long periods. Generally, we prefer the middle shelf to culture the embryos for long periods, and the dish is also kept in the middle of the middle shelf, as because the prolonged exposure to suboptimal temperatures can reduce the rate of blastocyst formation, and ultimately you will lose the objective if you falter in the correct placement of the dish in the incubator. This is pictures from labs where I've been, and I've seen that. Look at the top picture. The vent is directly opening, and the air vent directly is released on the face of the incubator. So this incubator should not be used for prolonged cultures because the temperature fluctuations will be a bit too many in this. Similarly, this picture in which the HVAC release duct just opens on the incubator as well as the laminar hood. This is not a very desirable arrangement. So having said that, I would also like to emphasize on the fact that door openings in the incubators cause immediate heat loss and should always be kept to minimum. Small internal multi-doors are an advantage because less area is exposed to the external when the small doors are open. Again, the third picture is from this lab in which they have used deflectors to deflect the incoming air away from laminar hood as well as the incubators. So another thing is incubator management. It is very important to manage the incubators, especially if you're doing batch IVF, even in routine IVF, because you should not be opening the doors every now and then just to check the patient's dishes and all. So what we can do is we can distribute the patient samples between all the incubators, and you should avoid the use of any particular incubator. So embryologists have a tendency to they develop this habit of liking a particular incubator and disliking a particular incubator. So that should not be the case. All the incubators should be optimally it should be technically optimal to support the blastocyst culture. What you can do is, if you have two incubators, you can have an alphabetically arranged culture system during transfer. So you should not be opening the incubators, checking which dish is lying where, or you can label the patient's name on the outside, so you don't have to open the incubator. Holding incubators can be separate, and in where you can incubate the media and do other things. Freshly prepared culture dishes and tubes should not be placed on shelves so that they are adjacent to gametes and embryos in culture. So generally, people have a habit of keeping sperm test tubes, semen test tubes inside the incubator. So they are very well supported at room temperature, and they should be kept outside. Introducing cooler plasticware and media will create a temperature gradient that might draw away the heat from pre-warmed dishes. A strict quality control should be managed while running the incubators. Again, this study by Tyler et al., they showed that large volumes, 1 ml with small overlay, can maintain temperature more effectively than small volumes with 1 ml overlay. Temperature loss was seen more rapid in solid versus glass stage warmers. And keeping a lid on the culture buffers temperature loss, irrespective of the volume of media used. And small volumes of media reduce their temperature very quickly after lids are removed, whereas a dish plus lid plus oil, this arrangement works far better compared to one without lid and dish. And another thing which I would like to emphasize, that benchtop recovers changes in temperature much quickly, because there is a direct transfer happening in a benchtop incubator compared to a large convection kind of transfer in box incubator. This is just an example of temperature recovery. It was fastest in a small benchtop incubator like Mink, whereas STEC small, which is a box-like incubator, took a lot of time to recover. So the amount of heat loss will depend on multiple factors, including air temperature. The ambient air temperature is extremely important. Airflow, as I said, that the vent should not be directly opening on the incubator or the laminar or the microscope stage. Type of culture media, whether a dish is covered by lid, whether it is covered by oil, temperature of the surface on which the dish is placed, the volume of media covering, and the oil overlay. The volume of overlay is extremely important. This is just an example of a thermocoin, in which they have shown that if you are using a thermocoin, a 5-minute exposure to suboptimal temperature just led to a fall of 2 degrees of temperature, whereas without thermocoin, it went up to 29 degrees. That is almost a 10-degree loss of temperature. So these small innovations can be very handy, as they maintain the heat for a much longer time. Benchtop incubators with oxygen control are recommended nowadays, because the blastulation rate is much higher, and the live birth and pregnancy rates are also much higher. The reason behind that is it works with ammonia to disrupt the pathway of glutamine and alanine transamination, leading to abnormal fetal development. So it increases the production of reactive ROS. So it has a negative effect if you're not using low oxygen incubator. And the resultant blastocysts have an altered gene expression and perturbed proteomic compared to embryos developed in vivo. So these are the studies which go on to show that embryos cultured at 5% oxygen compared to 21% oxygen demonstrated higher CPR and higher live birth rates, and obviously higher implantation rates compared to embryos cultured at 21% oxygen. So there are numerous studies supporting these facts. So each lab which is aiming to have a blastocyst culture should go for a low oxygen incubator, preferably a benchtop low oxygen incubator. If you compare humidified versus dry culture, there is a lot of literature which is coming in, which is supporting humidified culture. And it is said that an oil overlay is insufficient to protect against osmolality changes during dry incubation. And effect on osmolarity is less deleterious in culture systems which are cultured in humidified conditions. And oil properties are also not so important in humidified conditions compared to dry culture. So it is recommended that if you're buying a new incubator, go for a humidified benchtop incubator. And specific culture conditions such as oil volume depth, medium surface area to oil interface, ratio of oil to media, room humidity. So everything is important. So you should have the humidity of the room should be controlled, the temperature of the room should be controlled, the oil overlay should be maximum possible in a dish while you are making a dish. So if you consider a box versus benchtop incubator, then if you're buying an incubator, the iHERA sensor recovers CO2 levels much quickly within 2 to 3 minutes compared to a TC sensor. So always go for a incubator with iHERA sensor. Traditional big box incubators, they circulate room air through the incubator chamber and regulate the gas levels by the addition of CO2 and nitrogen. Thereby, they are susceptible to the inclusion of VOCs that are there in the room air. So if you're not using your ambient air, if it contains VOCs and you're using box incubators, then you're bound to have suboptimal blastulation rates. Whereas modern benchtop incubators, they flush the incubator chamber with gases provided in the cylinders, either pre-mixed or which are mixed inside the incubator, and they flush. So there is hardly any ambient air which is coming in these chambers. Any ambient air which is coming is flushed out by the pre-mixed gas or one which is getting mixed inside the incubators. So these incubators are protecting your embryos from the influence of VOCs and other impurities present in the air. So go for these incubators for prolonged cultures. Maybe if you have box incubators, you can use them for other purposes like embryo transfer, etc. pH of the embryos ranges between 7.1 to 7.2. And if the pH is not maintained properly, it can lead to altered gene expression. The cell number of blastocysts may go down, implantation rates may be low, and it might lead to fetal growth retardation if it implants. So you must measure the pH at some point of time, maybe in 3 to 6 months once. It will not be a bad idea. And factors influencing pH levels, again, generally I've seen that people incubate the media for a very short time. Minimum, you should incubate the media for at least 14 hours. You should reduce the frequency of door openings. Type of CO2 sensors, like I told in the previous slides, iHERA sensor will recover the CO2 much quickly, and again, the pH will also recover much quickly. So the volume of media and oil, again, you should have more volume of media and overlaid with oil. It increases, so it helps. The altitude is again important. If you're working at high altitudes, you should get the pH testing done and calibrate the CO2 accordingly. Generally, the CO2 levels are much higher in higher altitudes. So these are the gadgets which are used to monitor the pH levels, blood gas analyzer. And nowadays, I just came across a Bluetooth-enabled pH device, which also was working well. Single versus sequential media, and most of the research has shown. Gaurav will be emphasizing on this. He'll be talking more about this, but again, there are a lot of research has been done which shows that there is not much difference between the two culture system, and the blastulation rate is practically same, and there is insufficient evidence to recommend either sequential or single step media. I came across this article by Bayer et al., and they have said that in single step culture, they found an increase in aneuploidy, especially in young women. So this has also to be taken into account. Probably Gaurav will throw more light on this. And there was this article which said that the blastocyst formation rate and embryo utilization rate in ICSI group was significantly lower compared to that observed in conventional IVF group. So a piece of advice for my friends working in big corporates and other big chains who are not even trained to do IVF, they work like robots and they work like ICSI technicians. So they are just doing ICSI, nothing else. So a piece of advice for them that in normozoospermic patients, please go for IVF. Again, dish is something which is supporting the embryonic development for practically the 100% of the time the embryo is outside the body. So, and there is nothing physiological about a polystyrene dish. There has been seen that there is a well-to-well difference, and the variation in quality is very common in these plastic dishes. So you should inspect all the plasticware prior to use, and the fragments might just be there, and the damage dish has been damaged, and that a small crack will damage the embryo safe layer which is coating the dish. So don't use damaged dishes. It is important to store plasticware at an ambient room temperature away from sunlight, and it is important to give them some time before they are delivered to your lab. Allow them to off gas, and do not store them in incubator, because they might just they off gas in the incubator as well. So if you review the dishes, there are some dishes which are available with inner non-toxic and embryo friendly coating, as I mentioned. And IVF grade plastics are important. Falcon 353, 655 and Nunk, these series are approved by FDA, and they are individually wrapped and IVF grade dishes. And you should not. I've seen people culturing embryos in the lids also, and even doing ICSI and other things in the lid. So this is not a good idea, because the lids are not having the embryo friendly coating. So don't do that. Please culture in the dishes itself. Oil overlay is a must for any sort of culture, whether you're going for a humidified or a dry culture, because it not only prevents the evaporation of media and prevents from changes in pH temperature, but it also traps a number of VOCs. So you should use maximum amount of oil possible in a culture dish. Gas composition again is something which if you are aware, you will look into this, and you should always order medical grade CO2. And you should not only look at the purity of gas, but also look at the impurities present in the certificate provided. Some impurities may be in the range which they should not be there in a normal cylinder, and those impurities might just cause harmful might just create harmful culture conditions. So I'm sorry that I couldn't put in the levels of impurities in the CO2. It was in the other slide. I just missed on that. But then you should be aware. If you want, I can provide you that the levels later on. So just a brief, if I have time, I will just touch upon this. When should the culture be extended? When there is a repeated failure of implantation to avoid miscarriages and multiple pregnancies, and if you have got 4 2PN embryos and at least 2 grade 2 8-cell and 2 6-cell or 7-cell embryos on day 3, then you can think of extending the culture to blastocyst culture. The advantages are it gives you a self-selection after genomic activation. Blastocysts are more likely to be viable. It decreases the likelihood of multiples, improves implantation rates, and physiologically synchronized embryo transfer. And it gives you lesser risk of aneuploidy, and it gives you the option of doing a PGT, because nowadays all embryo biopsies are being done on day 5 stage. The disadvantages are there is a higher likelihood of cycle cancellation, lower chances of preserving the embryos, and possible epigenetic changes, and a lot of obstetric and perinatal complications like miscarriage and large for gestational babies. These have also been reported. So you must keep everything into mind, and then decide which customize according to the patient, and then choose which transfer is most suited for a particular patient. These are the KPIs. A blastocyst development rate, the competence value is 40%, and the benchmark is 60%. Implantation rate of more than 35%, and again the benchmark is 60%. So these are the targets which you need to achieve when you're going for a blast culture. Again, I just wanted to put this point that besides the KPIs outlined in the Vienna consensus, there are other markers which are influenced and which show variations much quicker than even a blastocyst development rate. The day 5 blast utilization rate shows a change even when there's a small change in the lab. So these KPIs should also be kept in mind, and they should also be monitored, besides total blast utilization rate and blastocyst development rate, which may change over a period of 3 months. But these day 5 blast utilization rate changes as soon as there's a change in the lab. So if you look at if I compare day 3 versus day 5, not much has been said about, nobody has recommended a particular day of transfer. So there are positives and there are negatives, which is not the topic of discussion for today, but I'll just quickly, touch upon that. So many scientists have worked on this, and many meta-analyses have shown that there is not much difference between the live birth rate per retrieval between cleavage and blastocyst stage, and the cancellation rate being higher in cases of blastocyst transfer, whereas the cumulative pregnancy rate is equivalent in both the day transfers. And this study showed that the cleavage stage transfer it's an ongoing study. It is going on, and they showed till now they have come to the conclusion that there is not much difference between a cleavage versus a blastocyst stage transfer. And this study showed that a lot of negative outcomes are associated with blastocyst transfer, such as risk of preterm, large for gestational age, and increased perinatal mortality. So in summary, the ideal day of transfer is still not known. There are advantages and disadvantages associated with both day 3 and day 5. And no particular is inferior to other. I mean, in my opinion, day 3 is not inferior to day 5 and vice versa. People are running after day 5, but then there are challenges which we have discussed. And if you can sustain day 5, if you can maintain the KPIs, then day 5 will work out to be better than you. And clinical judgment must be exercised while deciding day of transfer for the particular patient. But irrespective of the day of transfer, you should have a strict quality control program running in the lab to ensure optimal culture conditions, which will facilitate the blastocyst transfer on a consistent basis. With this, I end my presentation. Thank you so much, and I'm open to questions.
Thank you, sir. Thank you for the wonderful talk about tips and tricks on IVF laboratory. Now, is there any question? Because we don't
Rishita
see.
ji.
Can I ask a question?
Yes.
Yeah.
I also want to ask one question.
No, my question is very basic. Dr. Sarabpreet, first let me congratulate that you have extensively covered every aspect related to blastocyst culture. My question is maybe theoretical, but it is in a way practical also. So let us consider a new IVF unit. So the clinician has visited her friends and other established centers. Now she is starting her own clinic, and she has beautifully designed the lab. She has procured all the standard equipment, very good quality equipment. She has also hired a good embryologist with a good track record. Can she start culturing blastocyst right away?
So, Dr. Shukla, it's a very good question. I wanted to touch upon this in my presentation, but then, there was so much to cover in that short span of time. So it is said that it's definitely not recommended to start with a blastocyst culture because, you need to standardize your lab first. And doing a cleavage transfer may be an easier task compared to doing a blastocyst or extended culture. Because, ooplasm, the raw material in ooplasm can support embryonic development for at least 3 days. And after genomic switch, the lab conditions become more critical and the new DNA, it starts translating and, so it becomes tricky at times. So it is said that first you start with cleavage transfers, and then with the leftover embryos, they can be leftover for, an extended culture from day 3 to day 5. And after achieving substantial or satisfactory blastulation rates, then you should think of doing blast transfer consistently. Even with you said that the embryologist is established, the clinician is established, but establishing the lab and lab conditions, it does take some time. So I will not jump into doing a blastocyst transfer right from the first cycle. I'll rather grow my lab and mature it into a decent lab with satisfactory KPIs for cleavage stage transfers, and then think of moving to blastocyst.
So that means once you have a confidence on your entire system, not just the laboratory, but also the clinical system.
True.
So then only, and it's not just the clinical pregnancy rates, but once you have substantial data to support that your live birth rates are good, So probably that is a gold standard that, yes, now we have a confidence that our laboratory and our clinical environment is working well, and now we should start doing blastocyst culture. So thanks very much for your elaborated talk. Thank you.
Thank you, Rajesh.
Can I have one question, Yoshita, here, with your
Yes,
permission?
sir. Yes, sir.
Thank you, Saraprit. Such nice explained presentation. I just want to know one basic question where I am little bit confused now. We all know you emphasis very much on the temperature part in the lab. So still now there is a doubt in my mind. I explain it. It is my question that there is a recommendation that you should keep slightly elevated temperature of your working platforms when you are working in routine, when you are screening, when you are doing. So what is your say on that? Should it be recommended to have little bit 0.1, 0.2 degree slightly higher than 37 degree, or you will more focus on the airflow and all, and you want to keep your all working surfaces at 37 degree only? Because it is in common practice that when we are performing ICSI, it is a little bit time is required. So they say that it will be better if you keep it slightly at an elevated temperature. So for example, 37.5 or 37.4 instead of 37. So do you recommend this or in today's scene?
Completely agree with you. For ICSI and workstation laminar hood, it is recommended to keep the temperature a little higher, because ultimately you are measuring the temperature in the drop and not in the plastic. But in cases of incubator where you're leaving the dish for a very prolonged period of time, where it will ultimately achieve 37 degrees, and it will not be the results are not optimal if you culture it on 37.2 or 37.4. It is definitely not recommended to set your incubator at a higher temperature. But yes, for brief, where you are having brief exposure, because ultimately, when you're bringing the dish from incubator to your laminar hood, there will be a slight drop in the temperature. And keeping the stage at a 0.5 degree or 0.3 degree higher temperature might, allow a faster recovery, as well as, even if you are keeping the dish for a prolonged period of time. Suppose if you are keeping the dish for warming, a high days dish or an ICSI dish for warming on the laminar hood, or you're doing ICSI on a ICSI station, then also a slightly higher temperature is recommended. But because ultimately you're not measuring the temperature in the lid, in the drop, you're measuring the temperature on the stage, how much heat is getting transmitted, and what exactly is the temperature in the media drop. That is more critical and more important compared to the temperature on the stage.
And I think many of the petri dishes doesn't have a direct contact with the surface. Also, there is a slight gap in between.
There is a air gap which acts like an insulation, and it doesn't transmit the heat directly. I had all those slides, but this was not a presentation on temperature.
No, that's okay. This was one basic question that we all talk very much about temperature. So increasing temperature of our working station or working places might be helping, or I don't know. So anyway, thank you very much for kind presentation. Thank you.
Thank you, sir.
Thank you, sir. Now I welcome Dr. Gaurav Kant. Dr. Nidhi, please share slides. He's a co-convener of SIG Andrology IFS Society in 2022, and co-convener from SIG Embryology in Indian Fertility Society from 2018 to 2020, and he is a senior embryologist at Akanksha IVF Center, and he is a first embryologist to be certified by both International Society, American Society of Reproductive Medicine in 2016, and European Society of Human Reproductive and Embryology. He is also certified by Indian Fertility Society and Global Fertility Academy, and he did 11 international presentations in ASRM and ASHRAE and IVF, and he's a He's a blastocyst. He has done his training in blastocyst biopsy and cryopreservation from Barcelona, Spain. So welcome, Dr. Gaurav.
Thank you so much, Yoshita, for the kind introduction. So nice of you. Can I share my screen?
Yes, yes.
And he is multitasking embryologist who can handle all those things from his car also.
Yeah, true, sir.
First of all, I'm so thankful to you guys for giving me this opportunity. I cannot say no to Dr. Ved. He's always so supportive to all of us over here. So there is a flea market in Delhi today. That is Boho Bazaar. So I cannot miss it. I have done lots of work today and I have this presentation and I want to enjoy some time in the flea market with some booths. So the topic given to me is whether single step media is good or a sequential media is good to form the blastocysts, what we actually want in the lab. So for the basics, what is a single step media? We generally do ICSI and put the fertilized oocyte or the zygote in a single media and we culture till day 3, day 4, day 5, and we don't change the media generally. That is a single step media. And the sequential is where we change the media on day 1, that is on fertilization, where we have zygote, and day 3, where we have the cleavage 8 cell stage embryo. So here we have fertilization media, cleavage media, and the blastocyst media. So the difference between these two is the single step media says, let the embryo choose what it wants. We put everything together, all nutrition, whatever is there, we put it together and let the embryo choose. He knows what is best for the embryo. And what is sequential is we go back to the nature, what is happening inside the body, what kind of nutrition is there in the fallopian tube, what kind of nutrition is there in the uterus. So it is basically designed according to the nature, what is there in our body. So some people say that if you allow people to eat, they'll become like this, they can eat anything. So why not to be natural? Why not to go for sequential media, what is there inside, and we should follow it. So there is always a debate that whether we should use a single step media or a sequential media for making a good blastocyst. So although there are multi-factors which affect the blastocyst formation as described by Dr. Talwar and Dr. Sarabpreet, the age, the hormones level, the quality of the oocyte, the quality of sperm, whether you're doing IVF or ICSI, the embryo quality, how your lab is performing actually, it is also one of the factors. And especially the diet of the patient, especially in India, where we eat very less amount of protein. So now coming back to the data topic where the blastocysts, which media we should use. So when I was thinking about it, that which kind of media we should use, so I came to 2 conclusions. One, we should have some evidence to support which kind of media is important. And second, there are some arguments, there are some comfort while using the media. So which type of media there we should use? So this is a paper, basically an RCT, which was presented in Lisbon in 2015. So they presented a data of 3,652 embryos, you can see. And they can simply say, this is maybe I'm going to conclude in my slides later on, but they say that there is no difference in the blastulation rate. There is no difference in the aneuploidy rate, and there is no difference in the clinical pregnancy rate, whether you use single step media or you use sequential media. So there is another paper which says and talks about the blastocyst formation rate. They have 260 cases, and they showed if you use a single step media, there are higher chances of making the blastocyst. Higher means what? 51.5%. While you use sequential, you have just 40.7% of blastocyst formation rate. So whenever we talk about the use of something, we look for clinical trials. There is a beautiful trial known as Summit trial. That is a sequential versus monophasic media impact trial published in 2016. And that trial says that the sequential has an edge. There, the blastocyst formation rate is 38.7%. While we use single step media, it is just 32.6%. So later on, more people came on, and especially a group of Danilo Simadomo, which is a very big group, and they have a cycle of around 1,600, and they compared and says that the single step media, if you use it, you make 38.7% blastocyst. In sequential, you have 34.3. So there is an edge in this paper using the single step media. But they also showed a very important thing, that no blastocyst formation rate. That also happens when we are in the lab. We want every oocyte or zygote to turn up into a blastocyst, but that doesn't happen. So when you use a sequential media, there is 24.7% chances that you at the end don't have anything to transfer, anything to freeze, and nothing will form, and embryo may arrest at the end, and 20% chances in single step media. So, and especially when you talk about data, when you look for bigger studies, you look for systemic reviews and meta-analysis, and there is a golden opportunity when you get the systemic review meta-analysis of RCTs. So this is one of those RCT of meta-analysis of RCT by Fontares, and he says that there is a higher blastulation rate while using single-step media. But at the end, there is no difference in the blastocyst for top quality blastocyst. So at the end, what you're going to use, as you can see in the first plot, at the end, what you're going to use, the top quality blastocyst is same, whether you use a single step media or a sequential media. But you can make more blastocysts than single step. So there's another systemic review and meta-analysis which talks about the ongoing pregnancy rate. Does it impact whether you're using a single step media or a sequential media, and you make the blastocyst, and what is the outcome at the end? So there is no difference whether you use a single step media or a sequential media, the pregnancy rate is same. So Dr. Sarabpreet was talking about aneuploidy, and he was showing an edge towards the sequential, but this is, here you can see summarized by Swain. There are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 studies which talks there is no difference in the aneuploidy rate, whether you use a single step media or a sequential media. So don't be worried, whatever you kind of media you want to use, you can use. There is no difference in the aneuploidy rate. So at the end, we can say that there is no difference in the blastulation rate when you use a single step media or sequential media. There is no difference in the clinical pregnancy rate. There is no difference in miscarriage, and there is hardly any difference in the aneuploidy rate. So what other factors could be there in the lab when we are thinking about the blastocyst? There is an embryo toxicity. Sometimes what we do, we put all embryo together and culture them. So there are beautiful studies. If you separate the embryos on day 3, you make A grade together and B grade in a different drop or a different dish, you make more blastocysts. So you can achieve a 61.2% of blastocysts by segregate or separating the good and bad embryos. So are we moving towards uninterrupted culture? We don't know. Sometimes we can think we should not disturb them, but at the end, some paper says that it is better to separate the embryos, good ones and bad ones. What about people who does batches and they just do ICSI and moved on? What about those unfertilized oocytes being something every minute into the culture system and disturbing the growing embryos? So there are studies which say that if you have unfertilized or lysed oocyte in the culture system, please separate them. It can lend to poor blastulation rate at the end. Some people also think whether we should renew a single step media. Is it important to renew a single step media when we are thinking about the culture system? So there is a beautiful paper by Nuno Costa-Burgess, a very good friend of ours. He published this paper in 2015, and he says there is hardly any difference whether you change the single step media or renew the single step media on day 3 or not. It is your wish, basically. So we are done with the evidences now. Now we are going towards the main arguments whether we should use a single step media or the sequential media. So my first argument is definitely minimum disturbance to culture system. Who want to disturb the embryo? You look at the beautiful papers of pyroconsensus to James Swan. They all say one thing: please don't disturb the embryo. Let them leave. Don't open the gate always, as Dr. Sarabpreet said. Don't touch them. Don't do anything. They are not happy to come outside and say hello to you. Just put them there. They'll be happy to be there. So it is an advantage of using single step media that you are not disturbing the embryos more. When sequential, what happens? You change the media on day 1. You change the media on day 3. Means what? You're manipulating the embryos. Means what? You're exposing the embryo to the light. There is change in pH. There is a change in temperature. So why to do it? So this definitely there is an edge towards single step media now. And we should not give this to the embryo. Yes, definitely when you're thinking about the benchtop incubators and the time-lapse imaging, definitely you are thinking about the undisturbed culture. And if you use these kind of systems, you can have a higher blastulation rate. In sequential media, there is one problem. Although I also use a sequential media parallel to single step, the issue is you have to incubate the media a day before. You can say that I'll not forget, I'm not a hurry to forget the embryos to incubate the media, but this can happen. Remember the Murphy's law. If anything that can go wrong will go wrong. So if you have the probability of doing something, you might miss it. So in single step media, you just incubate the media and don't think about it for 5 days. And there are autocrine and paracrine factors which impact the growth of the embryo. We all are talking about it nowadays. We are moving towards the proteomics and cytotomics, and we are talking about it. It's good embryos interact with each other and they love each other and they care for each other by secreting some elements. So these factors remain there when you use a single step media. And definitely when you think about the future of the culture system, yes, you have the artificial intelligence. You have the time-lapse imaging. So there, the role of single-step media is coming in a better way than sequential media. So at the end, by concluding my all slides, I'm slightly fast, but there is no difference in the blastulation rate or clinical pregnancy rate when you use single or sequential media. But if you are thinking about the autocrine and paracrine factors, if you are thinking about the comfort and making less mistakes, and you are thinking about the future, like if you want to use TLM or artificial intelligence, then you can use single step media, or although there is no difference in the outcome. Thank you.
Thank you, Dr. Gaurav, for a wonderful talk about single and sequential. Is there any question from our attendees?
I can't see any question from chat box.
I have a question if I'm allowed to.
Yes, sir. Sure.
Thank you. So Gaurav, you are as good as always. Again, question for the beginners or the newbies. Let us consider this situation that today is Saturday and we have a pickup on Monday. So what if I prepare my dishes today itself, because tomorrow it is going to be closed? Gaurav?
Yeah, that's actually always a debate. So as you know, with the time, when you give the heat to the media, you always look at the increasing ammonia concentration. You talk about those things and you say that the media is actually designed for 5 days only. We should not culture more. But I take the liberty, I don't lie to it. I ask my juniors, it's okay. You need not to be that much conscious of taking a liberty of a day or 24 hours. We can incubate media 48 hours before also. I do that. And I have not found any difference. Because in my system, in my lab, I use both sequential and single step medias, and I don't find any difference in doing it. So we are also human.
As such, Gaurav, you are not culturing the embryos in this. You are just equilibrating the medium. So in fact, there is no metabolism. The only concern is whether there would be any osmolarity shift or the evaporation or something like that. But since we have this robust culture system, and as you have shown already in your talk with different slides and references, if you do undisturbed culture for 5 days, it is even 6, like we are now doing day 6 or day 7 blastocyst transfers also. So it is not going to make any significant difference if you equilibrate your media a day prior.
Yeah.
Thank you very much.
There is a one question from in chat box. Mr. Pritam Chatterjee is asking, vitrification is done on room temperature. Why is it so? if it is established that lower temperature interfere with the mitotic spindle of embryos. Dr. Gaurav, can you?
Yeah. So, to dear friends, so there are some companies, those who try to do it at heated stage or temperature as well. So don't look at that perspective basically. Uh, where Dr. Sarapreet was talking, he was talking about the oocyte. The movement of spindle is there in the oocyte. The oocyte is the most sensitive, you can say, the cell right now when you culture the oocyte. That's when you grow from oocyte to zygote to the cleavage stage embryo to the blastocyst. And then the blastocyst is the most robust and which doesn't make any difference whether you do at room temperature or at heat. So to coming to this, okay, why they are doing it. So there is lots of research, and it's not like that people decided that we are going to do it to room temperature. Let's not do it heating temperature. So they come to this conclusion. Yes, at the end, what is there? The aquaporins, which allows the media or the cryoprotector to goes in, works better when you use the room temperature, and the movement of the media or the cryoprotectant is gradual when you use the room temperature. So they come to this conclusion at that.
Not only this, Gaurav, there are certain media which are hippies based, and there are a few which are MOPS based. So that is again because one need to understand the chemistry of MOPS and hippies. So I would suggest that you stick to the protocol recommended by the manufacturer, because they have optimized their system according to the composition of media. And also, as the basic biology goes, the temperature dependent processes, mostly they expedite the process of diffusion or the penetration of the cryoprotectant in the ooplasm, as you explained.
Thank you, Gaurav. Now let's move on. I welcome Dr. Pranay Ghosh. Sir, can you share your screen? He's a MBBS and MS and ONG, Maulana Azad Medical College, Delhi, and Diploma Reproductive Medicine from the University of Kiel, Germany. And he is also a ASHRAE certified clinical embryologist, topper in 2016. And he got a Hall of Fame embryologist in ET Health World Fertility Award in 2020. And he has done his M in Med Science ART from the University of Nottingham, UK, Distinction Student of the Year in 2012. And he is a specialist training in reproductive medicines, NUS Singapore. He has done his PhD in certified clinical embryologist from PGDIS Embryo Tools, Barcelona, and he is also executive members of IFS and A Society. So I welcome Dr. Pranay Ghosh.
Thank you, Yoshita. So thank you so much for the introduction, and let's move forward. Things would not be complete if I did not include this slide, because this is all that I've been thinking for. The only inspiration to get done with this presentation in the last 4 days was last moon panic. And believe me, I just got done with the presentation in the last couple of hours that I've been sitting here with you. Again, would like to thank Dr. Ved Prakash for having me here for delivering this talk on a very precise topic, not just blastocyst selection, but whether it is the ICM or trophectoderm that matters more while we are selecting a blastocyst. So we now know that the blastocyst is the holy grail of the embryology lab. If we attain a good transcribable blastocyst that translates into a live birth, that's what we are all yearning for. And this is a slide that I included. I just made while I was listening to the previous 3 presentations, it doesn't matter if you have an optimal stimulation. It doesn't matter if you have a good IVF lab and you have a good culture media. Unless and until you are optimizing your blastocyst selection, and especially for single embryo transfers, you're not gonna have adequate patient retention. So it matters a lot to us in the current era that we are able to give good results at a quick time. The patients have, unfortunately, less patience for repetitive attempts, especially if you are offering them single embryo transfers, and it makes a lot of sense that we are able to pour in all our efforts in optimizing blastocyst selection for single embryo transfers. So this is a very overwhelming slide with a lot of videos, and this just goes on to reiterate the fact that selecting blastocysts is not an easy job, especially if you are having a good blastulation rates. Making blastocysts is not the end of the story. For you to be able to choose the best blastocyst to give the results in the first or the second attempt and have the patient with you, the patients are not going to stay with you even if you have 10 blastocysts frozen. They're going to move their embryos across to centers if you fail to have results in the first 2 or 3 cycles. So therein lies the importance of good blastocyst selection. So before we move on, I'll just I want to give you an overview of the pre-implantation development leading to blastocyst formation. And we can see there are the proper lineage segregation is ensured by 2 cell fate decisions. The first giving rise to the trophoectoderm and the inner cell mass, and the second leading to the allocation of primitive endoderm and the epiblast. So this is again a comparative model of the murine in the human species. In the mouse, the fertilized egg undergoes 3 rounds of cleavage, produces an 8-cell embryo that undergoes compaction. From the 8th cell onward, the cell division produces 2 population of cells, those that occupy the inside of the embryo and those that are located outside. The blastocyst cavity begins to form inside the embryo, beginning at the 32 cell stage and continues to expand as the embryo grows and matures into the late blastocyst. The CDX2 marker becomes upregulated in the outside future trophoectodermal cells, starting at the 32 cell stage in the mouse, while the OCT4 expression becomes limited to the inner cell mass in the early blastocyst stage. And by the late blastocyst stage, while continuing to express OCT4 ubiquitously, the ICM contains a population of cells that are nanopositive, which give rise to the epiblast, and a population of GATA6 positive hypoblast, the primitive endoderm cells. So when we see the human model, the development is similar in the humans, although compaction occurs at the 16 cell stage, and the mutually exclusive expression patterns of the CDX2 and GATA4 and OCT4 are not established until late blastocyst stage. So I would advise all the viewers to take this opportunity to revise their pre-implantation embryonic development and read the cell polarity models of the inside-outside hypothesis, the cell polarity model, till what stage is the human blastoma totipotent, and so on, which is outside the scope of this presentation as of now because of the paucity of time. So today we'll be talking about blastocyst selection, and as for any other modality in embryology, it is to increase the clinical pregnancy rate and the live birth rate. Most importantly, a blastocyst selection tool is to enable elective single embryo transfer. So this is what I would be emphasizing. And it is to decrease the time to pregnancy and miscarriage rates. When I say single embryo transfer, it is the single most important indication for me to be choosing blastocyst. Because if we look at India, we still are doing a lot of double embryo transfers, if not more. And a recent study of just about 113 couples in Mumbai done by the iHERA revealed that 45% of the pregnancies via ART resulted in twins or triplets. This figure is at least 9 times that of what has been achieved in the UK. The UK HAPA, they started with the initiative of having a 10% multiple pregnancy rate by the end of 2010, which they were not able to achieve by then. But as of today, that figure stands at just about a little above 5%. So only 5% of pregnancies arising out of ART are multiple pregnancies in the UK. So we have a long way to go. And we can see this from this statement by a renowned founder of a renowned fertility clinic chain in India. When they talk about offering SAT and DET, they say that they believe in SAT and DET. So we are to change our thinking patterns. We can't be collectively talking about SETs and DETs in the same rate. And they go, this lady, she goes on to say that because transferring 4 or more embryos is not known to increase the success rates. Oh my God, this needs a lot of recalibration of our minds. You cannot be even thinking about talking of transferring 4 or more embryos. So my point is that elective single embryo transfer is the way forward. And especially for the blastocyst selection talk that I'm going to elaborate on, all the evidence can be generated only if we are doing single embryo transfers, and it is because SET is an ideal model for analyzing and predicting the value of each morphology parameter, whether it is a trophectoderm or the expansion or the inner cell mass. So when we talk about blastocyst selection, we have various parameters like developmental speed, what days the blastocyst form, the degree of expansion, the trophectoderm grade, the inner cell mass grade. Then there are some additional indices that I'll try to cover in either trophectoderm or ICM, and a few other modalities that we'll not be talking about, like PGT and timeless microscopy. We are well versed with this Gardner's and Schoolcraft's modified scoring system, which is based on the degree of expansion, the grading of the trophectoderm and the inner cell mass. And we are using that in our routine laboratory practice in one way or the other. We're also aware of the, We're also aware of this scoring matrix that we routinely use intentionally or unintentionally. And we can see that all of our desired embryo transfers are scattered around this blue area where we have the grade A trophectoderm and the adequate degree of expansion and grade ICM, and we end up discarding the grade Cs and the unexpanded blastocysts. So when we talk about blastocyst selection, this meme, it comes into my mind, the proponents of the degree of expansion, the proponents of the degree of the grade of ICM, and the proponents of the grade of trophectoderm. It's an ongoing debate. There's evidence regarding each and every one of this school of thoughts, and I will briefly try to touch upon each of these. So when we talk about degree of expansion, we need to be very mindful of the timing of the observation. It needs to be around the stipulated 116 plus minus 2 hours, and keep in mind whether you're doing IVF or ICSI, because a couple of hours advancement in the ICSI embryos. The Gardner system that was proposed by Gardner and Schoolcraft was initially based on the degree of the blastocyst development in the sense that it was based on the degree of expansion. And it was felt that the expansion was important because it indicates the embryo competence in terms of the capacity of the trophectoderm to have sodium potassium ATPase channels on the basolateral membrane. And if you have a good trophectoderm, it means that the embryo is more competent to be able to do so. The initial systems, whether it was Gardner or Schoolcraft or the Docras, which we don't use anymore, laid more emphasis on the blastocyst expansion, that is the size of the blastocyst cavity. Shapiro et al. In a study found that the diameter of the transferred blastocyst was a single most significant variable in predicting the clinical pregnancy rates. And interestingly, the only data that we have prospectively collected in large multi-center trial, because all the other data, whether it is regarding expansion or ICM or trophectoderm, is retrospective. So we have the only prospective data coming from this large multi-center trial, which has shown that of all the 3 blastocyst morphology parameters, it was the degree of expansion that was the most important parameter. This is another study by Mustafa. It is a very recent study. It was done in 2020, and it also said that in a predictive model adjusted for all individual components of embryo grading, the day of blastulation was the only statistically significant contributor. I'll take this moment to talk about a little about the new Life Whisperer artificial intelligence based click and drag blastocyst selection model, where you don't need to have any hardware, you don't need to have fancy time-lapse modules. You can just upload your embryo images, the blastocyst images on this Life Whisperer platform, and you can see that it also follows the Gardner or the likes of it scoring systems, which have paid attention to the expansion grade, the ICM, and the trophectoderm. And even the newer AI-based blastocyst selection models pay a lot of emphasis to the expansion grades. As we can see, there's a lot of variance between the life history score for expansion grade 3 here and expansion grades 4, 5, and 6. Coming to the trophectoderm, I think there are a lot of proponents that believe that trophectoderm is the single most parameter which is predictive of the clinical pregnancy and the live birth rates. And it is possible that since the blastocyst is the stage of the embryonic development where the implantation is most probably dependent on the healthy trophectodermal cells, which have the capacity to invade the endometrium. That is the reason that trophectoderm has a very important role for at least having initial clinical pregnancy rates, even if the ongoing pregnancy rates might be dependent on the grading of the ICM, as is believed. So we need to be, we know that trophectoderm secretion of the HCG plays a crucial role in the embryo-maternal crosstalk, and HCG initiates the recognition of the pre-implantation embryo and acts as a LH superagonist to rescue the progesterone on embryo of the pre-implantation embryo. So we also now know that HCG affords pregnant women an immunological tolerance to be accepting the invading trophectoderm. Of note is the fact that higher grades of trophectoderm have been shown to secrete HCG at earlier time points and at higher levels in culture. We know in our minds that when we are transferring grade B, 3BB as compared to 5AA, we know that we'll get a higher beta HCG level of 1000, 2000 with 4A, 5A as compared to 3BB, where we'll still be having a lower level. And this is all anecdotal evidence, at least from my experience, that we know in our minds that the lower grades transfer to lower levels of HCG. This probably might be because higher grades of trophectoderm may translate into more HCG producing cells, and higher level of HCG leads to a strengthened signaling capacity of the unimplanted blastocyst. So all in all, we know that the trophectoderm samples, when they have been analyzed, they have expressed a lot of molecules, and some of these major transcripts belong to gene families that are involved in cell adhesion and cell communication, which are the chief functions of the trophectoderm. There's a study which was done by Kospinner, and it shows that the embryo morphology is directly correlated to the level of the beta HCG and the probability of ongoing pregnancy and live birth rates. But there are some studies that show that such correlation does not, it's probably just causal and it is not repetitive, and some people have not been able to replicate this. But still, the more proponents of trophectoderm morphology as being the single most important parameter to predict the ongoing pregnancy rate. And this is a very crucial study that's still probably dated. It was done in 2011, but this has been done by Alstrom and Thorir Haderson's group, which has a lot of repute. And they did a retrospective analysis of over 1,000 single blastocyst transfers, and they showed that trophectoderm was the only statistically significant predictor of live birth outcome. In this, they showed that between trophectoderm grades A, B, and C, there was a decrease in live birth rate of around 16% when the trophectoderm grade decreased from grade A to grade B, illustrating the impact of trophectoderm on live birth outcome, even when a normal ICM was present. They devised this table, which they called the GET model. And in this, from this table, when we see a woman of 35 years old, let's say, she has a chance of about 50% live birth when the blastocyst has a grade A trophectoderm and a grade A or B ICM, while the grade of expansion 3 and 4 had minimal effect on the outcome. If the same woman had grade B trophectoderm instead of grade A, then the chance, she would have to be between 25 and 30 years of age to have a chance of at least 50% live births. So there's not a large amount of difference between the grade A and grade B ICM, but for grade C ICM, there is a substantial difference. So all in all, it is worth noting that there were very few numbers of females with ICM grade C in this database. This study also suggested that the good trophectoderm is more important, and we can only think in our minds that we can rationalize this by saying that further development of the ICM, whether it is grade A or grade C, will not occur at all if you are having an incompetent trophectoderm. So the overpowering effect of profectoderm has been highlighted by the study. So if we say, for an example, a 4BA has a higher chance of liver than 4AB for all female ages. And in this study, interestingly, a 3BA had a higher chance of live births as compared to 4AB. Again, more studies that reiterate the fact that profectoderm predicts outcome of single blastocyst transfers. Again, study with around 700 cycles, and the live birth rates were 57%, 40%, and 25% for profectoderms grade A, B, and C. While between ICM grades A and B, the live birth rates were 53 and 52%. I confess that the live birth rate for profectoderm grade C was 0%, but that is because of lower number of patients recruited in this particular subgroup, and that it is for sure. I mean, it is but obvious that grade C profectoderm will have a very very low ongoing pregnancy rate. Also of note, it is to be mentioned that poorer grade of profectodermal cells have a higher chance of aneuploidies, monosomies, and abnormalities involving more than one chromosomes or large chromosomes. Coming to the ICM, so this is an excerpt taken from the Istanbul consensus, wherein they said that they agree that while the ICM has a higher prognostic value for implantation and fetal development, a functional profectoderm is also essential. So if I reword it probably comes across as that they are laying more emphasis on the ICM as compared to the profectoderm. So this is a very important study, even though it is very dated. It is probably 2001 when Richter did this analysis, and they said that the quantitative measurements of the ICM are highly indicative of the blastocyst implantation potential. And in the study, what they did was they studied the size of the inner cell mass, and they showed that ICM area less than 3,800 micrometers square was associated with lower implantation potentials as compared to ICM with more than 4,500 micrometers squares. Also in the study, what they did was they came up with a roundness index for the ICM shape. So a roundness index of less than 1.02 or more than 1.20. That means too round an ICM or too oval an ICM are also associated with lower pregnancy rates. And they show that the highest outcomes are with optimal size and optimal shape of ICM as compared to the other parameters. If you are having suboptimal size or suboptimal shape, then the outcome in terms of embryo implantation decreases. Another study, this was a recent study in the sense that it was done in 2016 by the group of Tim Child in Oxford Fertility Unit, so a very good center. And they came to the conclusion that there was no statistical difference in profectoderm drop in the profectoderm quality from A to B, while with the drop in the ICM quality from A to B, there was significant drastic decrease in the live birth rates. So this showed that the rates of clinical pregnancy were and the live birth rates were like 55% for grade A ICM as compared to almost half of it for grade C ICM. So it was on the basis of the study, it was proposed that you should transfer blastocysts with adequate expansion grade 4 to 5, good ICM, and profectoderm grade A or B would do. And though it was a retrospective study, but they included a lot of patients, so this was done over for over 10,000 SET cycles, so no mean task. So things are. We'll talk about a little about additional indices. Things are a lot clearer when we are deciding between 4A blastocysts like A and B. But for a 4CA, we know that we how to rank our embryos, and we are obviously going to choose 4A over 4CA, so not a problem. But now all the deliberation, all the evidence that we have examined would help us to choose whether we are going to choose a 3AC. That means a good ICM, but very scanty, almost nil profectoderm, or a 4BB. So you'll have to arrive this with your own data, because you cannot, just like time-lapse algorithms, you cannot just blindly follow some other clinics' outcomes. Your embryo culture system will perform differently, and over due course of time, you would, if you choose to have your numbers examined, you would come with your own grading. So you would probably in your clinic, 4BB will take less precedence for transfer as compared to 3AC, but for us, 4BB trumps 3AC. Then you have to be mindful that when you're selecting an ICM, you don't, and this is for just beginners, you don't confuse an intruded blastomere for an ICM. Then it also makes sense to choose a good blastocyst, an apparent 4A like this in the figure 8.1, be deselected for one which has a discrete ICM, not a oblong ICM like this, because this also has probably a lower chance of implantation and a higher chance of monozygotic twinning. We are to exclude any pseudoblastocysts which are not true blastocysts, so don't even include them in your blastulation rates. We usually come across blastocysts like these where we have excluded blastomeres, and we now know that the exclusion of blastomeres, the fate of all these inferior blastocysts, whether even if they show acceptable ICM or trophiectosomes, will be they show compromised outcomes in terms of implantation and live birth rates. When we talk about blastocysts with vacuolization of the ICM, we now know that we come across blastocysts with vacuolization, which is more in trophiectodome than ICM. But now it is important to deselect the blastocysts with ICM vacuolization as compared to trophiectodome vacuolization. So in the absence of a time-lapse algorithm or a AI-based blastocyst screening, it makes sense to have something like a blastocyst score, wherein you have a blastocyst ranking score, wherein you include your just not your blastocyst morphology, which is the sum of the scores of expansion and the ICM and the trophiectodome, but also the day of blastulation. So a 4A on day 4 or day 5 is not the same as 4A on day 6 and 4A on day 7. So in this blastulation score, in this particular study, they added a figure of day 2 figure of 2 to downgrade the scoring for a day 6 blastulation, and pretty sure a more inferior score for a day 7 blastocyst. So we can see that there's a linear correlation between the morphological grade, the scoring, the blastulation scoring, and the implantation rate and the fetal heart rate in this study. And in this study, we found that there was a linear correlation with the implantation indices, and that this blastulation score is a very valuable ranking tool in untested blastocyst transfers, and also critical for euploid blastocyst transfers. So patients who use PGTA will benefit from transferring the best quality blastocyst selected by this blastocyst score. This blastocyst score has also a good ability to predict euploidy, though PGT purists would not agree. So this score would also potentially be used for a PGTA consultations tool. Again, talking about Life Whisperer, we briefly mentioned that it is a click and drag over the cloud-based AI blastocyst prediction scoring system, and we've seen that it pays due regards to all the 3 parameters, whether it is the degree of expansion, the ICM, or the trophiectodome. And this was a study. This was presented at the last year's history, and they showed that the AI score showed stronger correlation with the trophiectodome than ICM. Apart from the degree of expansion, the ICM and the trophiectodome, the AI predictions is having a lot more morphological features that are not captured by the naked eye morphometric examination by Gardner score. And what these parameters are, we are not very sure about that right now. But certainly this is food for thought and food for future research, because there is something going on. That is why the Life Whisperer score is for now giving us a 10% higher implantation rates based on the blastocyst selection. But it comes with a pinch of salt. So it might go either ways. You have a 4A that you have graded 4A, and you think that this embryo is going to give rise to pregnancy, but the Life Whisperer score gives it a low viability score. So if you were to solely rely on this AI-based scoring system, you would not transfer this embryo, but this was transferred and this gave rise to a clinical pregnancy. The converse may be true as well. And similarly, another example, this is from their own website. They put on, if you want to test your morphometric scoring of the blastocyst, go on the Life Whisperer. play this quiz where they have 20 blastocysts, and you would be able to see how well or how badly you perform. So this 4AV, you predicted that this would, I predicted that this would lead to a pregnancy. Life Explorer also predicted that this would give rise to a pregnancy, but there was no clinical pregnancy. So we really don't know how, or probably we have to wait for more database, more data to come in to have a higher number of images for the deep learning model to give us a better predictability. So as of now, the scoring system is a juggling act between the expansion, the trophic and the ICM. And with that, I'd like to end the presentation and take up any questions. Thank you.
Thank you, sir. Sir, we have a question from Dr. Sanket. So he has asked, am I audible?
Yeah.
Yeah. So in one of your slides, you had mentioned that GATA4 expression, GATA4 expression is nil in the blastulation process, during the blastulation process.
Question Profectoderm and Sanket can talk to me later. Development at leisure, but I'll just address the questions on Profectoderm and ICM selection based blastocyst selection, because we have very limited time. We have already overshot time, and I'm pretty sure the people who have a lot of dilemma whether to transfer 3BA or 4AB or whatever.
So I just want to ask one question of mine. What is your choice? What do you prefer at your level among the 3 parameters? Or is it all the 3 parameters do you take into consideration during selection?
Yeah, when I showed you the last slide that it is a juggling act, they go hand in hand. You cannot have a grade 5 expansion and a nil Profectoderm and a nil ICM. So 5cc doesn't work. Similarly, for me, there's no 2A. You can adequately grade the ICM and the Profectoderm only after grade 2 expansion. So a 2A doesn't work. You have to wait. So probably what I would do is I would wait for it to expand more and probably do a late transfer. So you have to be very mindful. I mean, it is only if you're having a similar degree of expansion that this scoring would be a lot more difficult. So let's say if you're having it's very simple when you're saying 4AB or 4BA, because in my mind, with the evidence that we have, I'm a little clear about the message that goes on that for the initial implantation and the initial clinical pregnancy rate, the Profectoderm is the one that is responsible. But for a sustained ongoing pregnancy rate, the ICM plays an equally important, if not a more important role. And this might be contrary to some of the articles that I have, the evidence of which I have presented. But in my mind, I would still not choose a 4AC, but probably choose a 4BB.
Okay. Yeah. Okay. So one more question is there. Some cases at day 4, I find blastocyst. Is it ready for transfer or freezing? What about hatching blastocyst, and if it is there? So what is the...
We did a transfer we did a SCT of 3AA, especially since tomorrow is a Sunday. Nobody wants to come apart from me who has to do vitrification anyhow. I would be going. So, and it's a festive occasion tomorrow probably. So people are breaking their fast and all. So we ended up transferring a single 3AA. So you have to, and but I have to divulge that it was a time-lapse based model, and we could track this embryo right from the day 1, where we, at the time of fertilization check, we followed that, and we knew that this is the one that is going to give rise to blastocyst, because it had a very early cleavage. Not very early, because very early you have to be segregated. It had a relatively early cleavage, and everything was contract. So when you say that what to do with 4As or what to do with blastocysts on day 4, it's up to you. What do you intend to do with them on day 5? If you want to transfer, when you come in the morning, there'll be either 5AA or just about that is just about to hatch, or hatching. So hatching blastocysts can very well be transferred. They can very well be vitrified. It's just that if they are at the highest point of expansion, where they're just about to pop, when you are vitrifying, just be very mindful that it will be more prudent to collapse them to have a higher graft survival post-warming. So previously, when we were starting, we used to be a little apprehensive of finding 3As on day 4, because we used to do a lot of day 4 assessments, which we still do. because we knew that when we would come on day 5, they would be fully hatching. They would be hatching or fully hatched. But now knowing that this does not interfere with the embryo transfer or the embryo vitrification warming results, you can very well choose to do whatever you want to. If you want to vitrify them on day 4, vitrify them on day 4. But if you are intending to use them for vitrify and warm SCT, transfer them on P+5 and not P+4, because there would be no reason to. Unlike, don't treat them like day 6 blastocysts where you would be putting them on a P+5 endometrium. Just warm them a day prior to the actual transfer and use them however you want. Your other question was on day 6. What question was that?
So it's a hatching blastocyst on that day 4. The question was that. So will you freeze it?
It would never be a hatching blastocyst. So I can't say never, but in my experience, I've never found a hatching blastocyst on day 4. So deselect that. If it is a
it's abnormal process.
Yeah.
Early, very fast growing.
Freeze it. Whenever you start your PGT program, subject it to analysis, and when you have at least 10 hatching blastocysts on day 4, please let us know how they fare for their Eukaryote and aneuploidy levels, because the data, the literature says that you have to deselect very fast or very slow growing embryos right from day 2. So day 4 hatching is pretty, it's something that I'd right off deselect. Probably freeze and not use.
Abhay, sir, any questions from your end, sir?
Pranay, one question from my side. There is one blastocyst we cryopreserve on day 5, 4BA.
4BA.
And one blastocyst on day 6, 4AA. So I want to transfer. Which one I have to choose?
So again, if you have to answer critically based on the evidence, it would make sense to have one of these blastocyst scoring systems, wherein they have actually given they have downgraded the 4AA by 2 points, just based on its day of expansion. So it still ranks lower as compared to a 4B on day 5. And even if in the absence of this particular piece of information, if I were to choose that a week ago, when I did not do the research for this presentation, I think I would still choose 4BA over a 4AA if I was to do a SCT. So, also would want to make a comment regarding the profectoderm grading, especially for juniors. So when you vitrify seemingly grade B or grade C, actually not grade C, seemingly grade B blastocyst, you will notice that during the vitrification collapse and warming re-expansion, a lot of this so-called poor quality trophectoderm is not poor quality trophectoderm. It is actually the excluded blastomeres that were impinging on the trophectoderm, and the actual grading of the trophectoderm would come out when you have vitrified, warmed it. And we routinely find it when we are doing day 5 FUTs, that when you do a laser collapse, laser hatching, at the site of these excluded blastomeres, they actually tend to be pushed out, and you have beautiful looking trophectoderms, which you had previously at the time of vitrification graded a grade B.
Right. Absolutely right. Any other question, Nidhi?
No, sir. No, sir.
So now we, sir, आपको कोई question लेना है, Dr. Sanjay?
Manjeet, I can see one question here regarding culturing just 2 day 3 embryos to blastocyst. So there are 2 approaches. One is like my counter question: why do you want to go up to blastocyst? Previous speakers have already shown that there is no significant difference between day 3 transfer and day 5 transfers if your laboratory is very good, if your laboratory's KPIs are, reaching benchmark status. So the pregnancy rate doesn't differ that much. So if you have just 2 day 3 embryo blastocyst, and if the patient is ready, because I reckon if you have just 2 or 3 embryos, it must not be an OHSS case. So, and if the endometrium is good, conducive, why not transfer two day 3 embryos? But suppose there is some suspicion or something like previous failure, repeated implantation failure, and you want to confirm whether those embryos will reach blastocyst or not, or the quality of embryos are not good. So you just want to make sure that if there is any blastocyst, then only you will transfer. So if there is any indication and you want to go up to blastocyst culture, then only it is advisable. Otherwise, even in today's practice, if I have just 2 day 3 embryos, I would, and if it is not for transfer, I would rather freeze on day 3 itself than waiting until day 5.
So can we, Pranay, can you tell us about that? How many embryo we should have on day 3 to extended culture?
So there's a good, very good table given in. Can I share my screen? I can open that.
Yes, sir.
Just give me a second. I want to actually not quote it from the top of my head and have an actual figure coming out. So I'm sharing my screen, and this is a preview from. Can you see this?
Yeah, please.
Yes, sir.
So this is a table from the Gardner's textbook, and this would vary from your level of expertise. In the sense that if you're a starting clinic, when we started, our threshold for having for going on till day 5 was to have at least 5 grade A embryos on day 2. Day 2 is a day when we take a call whether to call the patient on day 3 or or still call them on day 2 and tell them that you're not having a transfer on day 3 and calling on day 5. So that is the importance of day 2 assessment for our unit. So that eventually got revised to 4, and at current we stand at 3. So today, if we have 3 grade A embryos on day 2, we feel pretty confident, and I should not overquote it, because anything, anytime anything can go wrong, and tomorrow I go and I'll find something else. But as of now, our protocol is very well defined that 3 grade A embryos on day 2, we go till day 5 with the hope that, with the pretty much assurity that we'll get a blastocyst on day 5. So this also depends on a lot of other things, patient's age, most importantly. Or even for a 40-year-old with 3 or 4 grade A embryos on day 2, I would not go till day 3 and day 5. I'll probably freeze a couple and perhaps try to talk to the patient what they want. If they feel that they are confident, they're fine with no transfers, which is a very sad situation to land up in, and which is very common for older women who still have good quality day 2, day 3 embryos. Even with higher numbers, I would not be tempted to go till day 5. But these are precisely the women that require a day 5 culture, because they are the women who demand a PGT from us. So things are very dicey. But as of when you ask me, you're very right. If you have 2, and Dr. Sanjay as well, if you have 2 grade A embryos on day 2 or day 3, I'm going to either freeze them or transfer them on day 3. And even if it's a frozen embryo transfer, when I'm warming the embryos, they go back on the same day. We are not culturing them.
Okay, right.
I'm going to stop this screen sharing.
Sir, चारू सर, sum up कर दें सब, vote of thanks कर दें हम.
कर दीजिए सर, बिल्कुल कर दीजिए.
आप स्टार्ट करिए, आप ही को बुलाया मैंने आपको vote of thanks देने के लिए.
हमने इनॉग्रेट किया था तो अब वोट ऑफ थैंक्स तो आप कर दो. एनीवे चलो. So Pranay, wonderful talk, wonderful description. As always, iHERA is committed for bringing up new issues and discussing on this platform. So on behalf of iHERA, I would like to thank each and every one of you, moderators, speakers, our iHERA founders, to give us such opportunity and good feast of academics. So once again, thank you very much for attending this webinar.
Thank you everyone. Thank you so much. Thank you, Nakul.
Also, thanks to Emcure and their team
Yes,
to make this happen.
thank you. बिना इसके तो कुछ संभव ही नहीं है असंभव है। और अच्छा था, मुझे आज बहुत ही अच्छा लगा।
Streaming is live, sir. अभी
बहुत ही बढ़िया रहा एक्चुअली में। अभी लाइव तो नहीं है नकुल?
Sir, we are streaming live, sir.
निशाद,
Yes, sir.
आप इसको प्लीज लाइव से हटा सकते हैं?
Yes, sir. Sure.
प्लीज।
Done, sir.
थैंक यू। मैं वो ही कह रहा था, मैंने कहा बहुत ही अच्छा रहा। आई डोंट नो, मतलब मेरे दिमाग में ऐसे ही बैठे बैठे आगे रात को 3 बजे के करीब मैंने प्रोग्राम बनाया था। ऐसे ही मेरे को लगा कि चलो प्रोग्राम डेट आ गई थी नजदीक और मैंने ऐसे बैठे बैठे प्रोग्राम
Nakul, live on custom live streaming service, it's written.
Okay, I will, Nishad, please pause.
हाँ सर, हो चुका है।
नहीं वो नहीं है वो। निधि, don't worry. It's not.
हम कुछ ऐसी कुछ बात नहीं करने वाले वैसे भाई जी, अगर कोई सुन भी लेगा तो बुरा नहीं। नहीं, मैं जस्ट वैसे ही कह रहा था कि मैंने ऐसे ही बैठे बैठे फटाफट से 4 लेक्चर बनाए मैंने, क्योंकि